Good morning to all of you tuning in this morning. I'm Dr. Jason Bolton, Vice President of Community Partnerships and Admissions for the Help Group, and I will be moderating today's webcast, My Child Was Diagnosed with Autism, Now What? Since August of 2020, we have offered more than 20 webcasts that have covered a wide range of topics, including the mental health impact of the pandemic in our youth, the benefits of psychotherapy for autistic individuals, the intersection between autism spectrum disorder and LGBTQIA+, COVID regression and learning disability, and most recently, improving school attendance. You can find each of those webcasts, as well as many more, and a virtual open house of all of our schools on our website at www.thehelpgroup.com/webcasts. The Help Group created some of the first specialized schools for students with autism many years ago. Today, we serve students with autism in similar developmental profiles from preschool through the age of 22 and beyond in our schools and other programs. Often parents find us by word of mouth, through internet searches, or professional referral after their child has recently received a diagnosis of autism. While this may happen at any age, and with more frequency is happening even later in childhood and young adulthood, the majority of parents reach us after their young child has been diagnosed. Our presenters today will be saying a lot more about this topic, so now I would like to tell you about who they are and as they lead us in this important discussion about what to do now after the diagnosis has been given. They will review the first steps to educating yourself about the diagnosis, talk about strengths-based approaches to your child's needs, and discuss available services and resources for you and your child. Dr. Lori Stevens is a developmental psychologist who has been working with children, teens, and young adults on the autism spectrum for over 25 years. She currently serves as the Help Group's Senior Director of Autism and Clinical Programs. Previously, Dr. Stevens served as the Director of Autism Spectrum Disorders at the Help Group. Her primary area of specialty is in designing social skills curricula, with a newfound passion for the changing nature of social expectations in the digital age. She has designed, run, and supervised social skills groups for children ages 2 through young adulthood. She provides individual, family, and parent psychotherapy, utilizing primarily a cognitive behavioral approach to a wide range of clients, and is available to see clients through the Help Group's Lumina Counseling Center. Dr. Anakari Ramirez is a postdoctoral psychology fellow in autism at the Help Group. She received her doctoral degree in school psychology from the University of California, Riverside, and is currently working towards licensure in psychology. Her passion is supporting children, adolescents, and their families through therapy, support services, and psychological evaluations. Dr. Ramirez's specialty includes working with children and adolescents who struggle with anxiety, depression, ADHD, ASD, and learning disabilities, and supporting families of children and adolescents with a range of behavioral and emotional difficulties. Now that you have heard about our presenters, those of you who have been here before know that we like to know a little bit about who is in our audience. You should now see a short poll pop up on your screen. Please answer the questions. I'll give you a couple minutes here to answer all of them. And once you have finished with the poll, in order to get that to not be in the middle of your screen, you'll have to X out of the poll manually. Otherwise, it'll obscure our faces during this talk. So here folks are coming in. I will sit here and wait for a good number to come in before I summarize the poll. We have about half who have answered. It's really good for us to know who's here every time. It's interesting. It's looking like there's a lot of new folks this time, which is great. Okay, we have a little bit more than 3/4 of the people have answered. So we ask, is this the first, have you attended any of our other webcasts? This is about our 21st or 22nd one that we've done since early in the pandemic. 3/4 of you, this is your first time, so welcome. I'm glad you found us, and I hope that you will continue to come to our webcasts that we hold about monthly. We ask if you're a parent, teacher, mental health provider, or others, and getting close to half of the audience is parents, and about 1/4 are mental health providers. We have a handful of teachers, and about 1/4 don't fit any of those 3 categories. We are asking a little bit about the interest in being at this webinar. And so do you have a child, or are you currently working with a child who's been recently diagnosed? And 70%, Lori and Anakari, 70% do have an association with a newly diagnosed child. And then we're very interested to know if you'd come to these, if we did them in person. We obviously started doing these virtually because of the pandemic, and we just have sort of rolled with that, but we're very interested in getting the community on our campus. So I'm encouraged to see that about 2/3 would be interested in coming to campus, and about 1/4 are still unsure. And there are some folks who would not want to. And our intention is to continue to do things virtually as well, because we certainly have been able to reach a much broader than local population by doing virtual things. I have a feeling that that's some of the no answers, because I know I saw some folks from Australia and Europe who were registered to be here today. It would be kind of hard for you to be here in person, huh? All right. Well, thank you for filling out that poll. We are honored that you have chosen to spend another hour with us, or your first hour with us. For those of you who are joining us for the first time, let me tell you a little bit about the help group. Among other social and mental health services serving the entirety of Los Angeles County, including outpatient mental health services and intensive family intervention programs. The help group operates 14 non-public schools in Los Angeles County for students with autism spectrum disorders, learning disabilities, ADHD, developmental delays, and emotional challenges. We contract with more than 80 local education authorities, meaning school districts or charter schools who act as districts, to provide special education and related services to more than 1,000 students. During this presentation, you may use the chat function to present questions that you would like the panelists to address. The chat function will when you chat, it will only be seen by the panelists. We may answer chat for everyone, so everyone might see answers or things that we think of to put out there, but your chat will only be seen by panelists. During the presentation, the presenters will get to some of the questions that you ask, but we may not get to them all. We have seen over previous webcasts that we can't get to them all, so we may follow up with an email that answers some of the more salient or frequently asked questions. And now I do have the great honor of introducing our first speaker this morning, so let's get to it. Here's Dr. Lori Stevens. Muted.
Thank you. It wouldn't unmute, so I was trying to say I can't unmute, but I guess that doesn't make sense. Good morning, everybody. I'm Dr. Lori Stevens, and I'm really excited to be speaking with you today. Because all of you have recently received a diagnosis, or your child has recently received a diagnosis, I just wanted to go over a little bit about the diagnostic criteria so that we can understand and all be on the same page, if you will, about what we're talking about. So the new diagnostic criteria, which came into being in about 2014, 2013, out of the Diagnostic and Statistical Manual, so the DSM-5, which means 5th edition. In order to get a diagnosis of autism, you have to meet all 3 of these specific criteria. So the first thing is that a child or an adult, but in this case we're talking about children, has to present with what's referred to as clinically significant and persistent deficits in social communication and interaction. So in other words, there's some type of social challenges and some type of communication difficulties. However, the communication difficulties do not have to be that a child is not able to use verbal spoken language. But it can also be that children talk too much. Children struggle with conversation, the give and take, and some of the more pragmatic or social uses of language can be more of an area of challenge. The second criteria is that all children need to demonstrate restricted, repetitive patterns of behavior. And this can include sensory challenges. So this can include what are considered to be stereotyped behaviors, that is the hand flapping, rocking, spinning, but it can also be children who, let's say, will only want to eat white food. So they might have some food aversions, they might have texture aversions, they might have very restricted eating. They can have repetitive patterns, let's say, of lining up toys, of wanting to do the same thing over and over again. So perhaps watching the exact same clip from a movie over and over again. And so both of these criteria, the social communication challenges and the restricted and repetitive patterns of behavior, have to be demonstrated in order for somebody to receive a diagnosis of autism. And then the third criteria is that the symptoms have to be present in early childhood. This doesn't mean that the child has to be diagnosed in early childhood, because as we know, many people now are being diagnosed much later in life. But what it means is that when you get a good diagnostic evaluation, it's going to include providing a developmental history. And in that developmental history, the clinician is going to be looking for where there are social difficulties, sensory issues, behavioral challenges, repetitive behaviors. Was all of that present from early on? Because autism is what's called a neurodevelopmental disorder, which means that it's something that is present from birth and stays with you throughout your life. Next slide, please. So when we conceptualize autism, we're really thinking of autism as being this triad of challenges. So that is, we have the challenges in social interaction, verbal and nonverbal communication. So remember, you can have a child who actually speaks quite well, but struggles to read body language, struggles to interpret tone of voice. So all of those kind of nonverbals. We also have the restricted repetitive patterns of behavior or thinking. And then we tend to have sensory processing challenges, which again is where children might be oversensitive to sounds, to lights, to taste, to touch. And so while that in particular isn't part of the diagnostic criteria, it's a large challenge that we oftentimes have to address when we're providing our intervention strategies. Next slide, please. The other thing that's interesting about the new diagnostic criteria, and I still call them new, even though they came out in 2013, just because it's the 5th edition, so we've changed the diagnostic criteria multiple times. As you might be aware, there used to be a lot of different diagnoses. So there used to be Asperger's, there used to be pervasive developmental disorder, not otherwise specified, and autism. And now everything is a diagnosis of autism. So you don't get a diagnosis of Asperger's anymore. You don't get a topic, that topic. I'm so sorry. I just saw the chat and saw the word topic. You don't get a diagnosis of PDD-NOS. You get a diagnosis of autism, and then you get a severity rating. So you can be level 1, level 2, level 3, with a level 3 being children who are considered to require very substantial support. So this is what might more commonly sometimes be referred to as profound autism or severe autism. And what it implies is that these are the children who have a lot more communication challenges. So whether that's spoken language or whether it's using a communication system like a PECS, picture exchange system, whether it's using an AAC advice like Proloquo Go, even those early communication deficits will be quite profound. And these are children who typically require a very high degree of supervision and support. They might not be able to become toilet trained or struggle to become toilet trained. And so that would be level 3. Level 2 is those who require substantial support. So this might perhaps be what we used to consider PDD NOS. So these are children who might not require as much one-on-one assistance or kind of constant supervision, but still really need quite substantial support in order to be able to maximize their potential. And then we have level 1, which are children who require support. And so we would kind of consider that maybe to be the group of kids that were previously diagnosed or would have previously been diagnosed with Asperger's. So children who might have slightly more advanced adaptive living skills, daily living skills, might have a little bit of a higher degree of communication, spoken language. All children communicate, as we'll get to in a minute, but in terms of actual verbal language. And then finally, we also determine when we're doing a diagnostic criteria whether the child presents with an additional intellectual impairment or whether there is no intellectual impairment, whether there's a language impairment. So that can be a little bit different than the social language. This would be more like expressive and receptive vocabulary, whether it's associated with a genetic, medical, or environmental cause. So, for instance, we know that Rett syndrome, which actually used to be part of the autism spectrum, oftentimes mimics autism. You have things like Fragile X, which can mimic autism, fetal alcohol syndrome, which can mimic autism. Doesn't mean, what it means now is that somebody can be diagnosed as autistic with fetal alcohol syndrome, which used to not be the case. We used to have to separate those. And then the other good thing about the new criteria is that you can also now be diagnosed with other neurodevelopmental, behavioral, or mental disorders. So in other words, you can now be diagnosed at the same time as autistic and ADHD, which again, in the past, sort of autism was thought to subsume all of your presentation. And what we know now is that autism does not subsume all of your presentation. Autism is a subset of what your child is experiencing and presenting with. So anxiety disorders are very common. ADHD is very common. There's other diagnosable comorbid symptoms that we typically see in the autistic population, and those now are able to be diagnosed separately. Next slide, please. So one of the things that I always like to talk about and really encourage parents and support providers and teachers and family members to really understand, most people think that autism is like this linear thing, right? And I think the level system unfortunately supports that thinking, because it's kind of like, oh, you just require a lot of support or you require a little support, rather than looking at it as in some areas you might require a lot of support, but in other areas you don't need as much support, and it being variable. But what people have come to think is that, there's a high functioning and a low functioning autism, and that low functioning children have more autism and higher functioning kids have less autism. But that's not the case at all. There's no such thing really as high functioning and low functioning. And autism, is not a linear concept. It's really this sort of melding together of various traits and various skills for which you can either be kind of highly impacted or less impacted by that. So if you look on the right-hand side of your screen under where it says what autism really looks like, we are looking at all of these different traits. So social challenges, intense focus or interest, sensory sensitivities, needing a high level of routine and repetition. In each one of these areas, a child might have a particular pattern. So they might have significant social impairments, but they don't have a lot of sensory sensitivities. You might have a student who has quite a lot of communication difficulties, but doesn't really show intense interest and seems to be fairly flexible and things like that. So hypothetically, when we think of autism this way, we realize that there's this entire spectrum, hence the word, where you can kind of be anywhere and still be autistic. So if you look on the right-hand-most part of your screen, under the 3 hypothetical autistic individuals, you see that each one of those 3 have a very different presentation, but each one of them has the same diagnosis, which is autism. And so when we're talking about even trying to give a talk like this, there's never one way to do anything with the autistic population. We really need to look at the specific traits and the specific presentation of that specific individual, and then design our intervention strategies around how that particular child presents, because there's no such thing as like a prescription for autism, which we're going to be talking about in a minute. Next slide, please. Okay, so now that we're kind of, we know at least how we here at the Help Group conceptualize autism and what the Diagnostic and Statistical Manual says, and now your child has been diagnosed, so now what? One of the things that I want to really state very clearly is that getting a diagnosis of autism does not put any caps on your child. We believe in taking a strengths-based approach, and all children have strengths. And particularly on the autism spectrum, we oftentimes find what used to be called splinter skills, but these really intact areas of strength. So you might have a child who's got a lot of behavioral challenges and who has some communication challenges, but knows the route to every single place you're going to go, but recognizes every single person they've ever met and knows who they are. These are amazing skills. And that's a strength that we then want to build on as we're thinking about how do we plan intervention strategies. And also, autistic people have achieved just about everything that a non-autistic person has done. So autistic people get married, autistic people have children, autistic people have gainful employment. So don't think of autism as closing a door on your child. It absolutely doesn't. Getting the diagnosis opens the door. So now we kind of know what are the things that we want to try and help, and what are the things that we're going to be able to say, this is just who our child is. Our child is neurodiverse, and we're going to affirm their neurodiversity while helping build up the skills that they kind of want to develop. Because it's a neurodevelopmental disorder, autism cannot be cured. And if you have one takeaway message from today, it's to please stay away from anything that talks about the curing of your child. So number one, autistic people don't need to be cured. And number two, it doesn't really happen. What happens, in my opinion, with a lot of these cures is that we just teach children how to mask who they really are and how to and how to kind of not be their authentic selves. That doesn't mean that there are not traits of autism, as we're going to talk about in a minute, that can't be worked on and improved. But as a whole, an autistic person is an autistic person for life, and that's okay. Your child, of course, is the same child as they were before they were diagnosed. The only thing that the diagnosis does is give you a roadmap now about where you might need to go. The goals of a service or intervention should never be to fix or to normalize your child. It's really to help your child function at their fullest capacity and to be the person that they want to be and achieve the goals ultimately that the autistic person wants to achieve, not so much what the non-autistic people think they should achieve. The first thing that you want to do when thinking about your child is to think about what are the areas that seem to be most impacted. So for most very young autistic children, the first thing that parents notice is the communication challenges. And the lack of intact communication oftentimes then leads to an increase in behaviors, because behavior is full-on communication. And when you don't have the words to express, or the pictures or a device to express for you how you're feeling, your behaviors are how it's going to come out. So most parents oftentimes think, I really need to address the communication. If my child could only communicate. And remember, communication is not just being able to verbally speak. There are lots of ways to communicate, whether it's through ASL or, like we were saying before, picture exchange systems and AAC devices that can actually speak for the child. But the goal would really be to get your child to be as communicative as possible. So look at what appears to be the most impactful for your child and work on teaching those skills and those strategies. Remember, Google is not always your friend. And by that, I just mean that if you go in and you type in newly diagnosed autism, you're going to get over 1 million hits. And it's very hard when you're a new parent, and if you don't have a lot of experience with autism or knowledge of autism, it can be overwhelming. It can lead you down some paths that you don't want to go, especially about fast cures and things that things like that. So I think the best thing to do is when you get the diagnosis is to turn around and join a support group and to bond with other parents, because you are not alone. There are many, you know, it's I think the prevalence now is 1 in 54 or even 1 in 46 or something. So if you think about that, that means a lot of parents that you know have gone through what you have gone through. And the best thing to do is talk with other parents and to also talk with autistic adults, because lived experience is very important for you. I think oftentimes when you hear from older autistic people, it gives you hope and you realize that this is something that your child can become. And I think that hope is really important. So I'm now going to hand it over to my colleague, Dr. Ramirez, who's going to talk to you about some specific intervention strategies.
Thank you, Dr. Stevens. So what's the next step following a diagnosis? Usually, depending on the child's age, if you're diagnosed before the age of 3, children in California can receive early intervention services from their local regional center, which again is determined by the area that you live in California. And this includes children with autism or who are at risk for other developmental delays or developmental disabilities. So many children receive various services such as occupational therapy, physical therapy, speech therapy, and even applied behavioral analysis or ABA through the regional center. And an online application is available both in English and Spanish for parents who have not sought this resource. Following regional center, once a child turns 3, the child's school district of residence, which is determined by your zip code, so again, where you live, becomes responsible for providing special education services and interventions. This transition from regional center to your school district usually begins several months before the child turns 3, usually around 2.5, so that your team, including you as a parent, can develop an individualized education plan or an IEP so that it is ready and set to go by the time your child is 3 and goes into the public education system. In some cases, as a child is older, or services can be provided by the regional center after they've turned 3. However, they must be diagnosed with a developmental disability, and that disability must be substantial. What do we mean by substantial? It's just that the impairment must be in at least 3 of the following categories, which includes communication skills, learning abilities, self-care, mobility, self-direction, independent living skills, and as they grow older, economic self-sufficiency. Next slide, please. So after you've either gone through the regional center or you're at your school of residences, there are various treatments that can be provided depending on the areas of support that a child needs. Generally, these can be broken down into the following categories, which includes behavioral treatments like ABA or pivotal response training, PRT, developmental treatments, which includes speech therapy, occupational therapy, and within occupational therapy, there's feeding therapy, sensory integration, and physical therapy. In terms of areas of social relational, this includes floor time, which I will discuss in a little bit, and Early Start Denver model, which very briefly is a play-based behavioral therapy for children ages 12 to 48 months, so when they're really little. And then there's also psychological approaches, which can help people with ASD or autistic individuals cope with anxiety or depression or other mental health issues, such as through the use of CBT or cognitive behavioral therapy. Next slide, please. All right, so as promised, with a little bit more detail, one common therapy, which is available both privately, sometimes in schools and insurance-based, is applied behavioral analysis. ABA is an approach to understanding and changing and teaching new behaviors, and it applies science of what we call behaviorism, which is bringing about meaningful change to an individual's actions. There are generally 3 key ideas behind ABA. And this includes that, one, behavior is a form of communication. So all behavior is a form of communication, whether it's screaming or ignoring someone. The assumption is that this child is trying to communicate something with you. The second is that human behavior, or all behavior, is influenced by the environment, or more specifically, events or stimuli in the environment that might increase or decrease the likelihood of a behavior occurring. And then also that behavior that's followed by positive consequences is likely to happen again. And this is usually assessed through ABA using an ABC model, which stands for antecedent, behavior, and consequence. So usually trained therapists look at the antecedent, so what happens immediately before the behavior that we're observing, the behavior itself, and the consequence, or what happens immediately after the observed behavior. In our little example here, if a child screams, and a behavior analyst would look at what happened before, which is mom leaving the room, and what happened after, which is mom comes back into the room. And then strategies for changing or teaching new behaviors or encouraging other behaviors would be based on prevention strategies and both how someone responds to the behavior that is occurring. Next slide, please.
I just want to jump in here really quickly and talk about a couple of the caveats that exist regarding ABA. So the first thing that I want to be sure that everybody understands is that behavioral principles in and of themselves are not what is classically thought of as ABA in relationship to how we teach autistic children. Behavioral principles guide everybody's behavior. All of us are guided by behavioral principles. So I don't think many of us enjoy stopping at red lights, but we do. And we do because the consequences of not stopping at the red light are strong enough to control our behavior. So I don't want to get in an accident if I run a red light, nor do I want to get a ticket. So yeah, I'm in a rush, but I'm going to stop at red lights because of the consequences. So behavioral principles in and of themselves are not bad things. What happened is that this concept of ABA, and I personally think that the terminology ABA got sort of usurped within the autism intervention community. But really, we're talking about particular programs that were given to children that were considered to be DTT or discrete trial training or VB programs, which were verbal behaviors that were extremely overly based on compliance. The child must do what the adult is telling them to do, regardless of how they're feeling, regardless of whether it was a needed or necessary skill, whether the child, just was kind of, feeling anxious or was having some attentional difficulties at that time. And what happened for a lot of people who went through ABA, so autistic people now are talking about their experiences in ABA and saying that it was extremely traumatizing because it led to them feeling bad about themselves, feeling like they were broken. Like if they weren't neurotypical, right, or if they stopped being neurodiverse, then they would be an okay person. And that was the message that they felt they were getting from ABA. And that is never a message that I don't think anybody wanted to give, but it's certainly not a message that we at the help group could condone, because that's not at all our vision. And it's not what we would ever want anybody to say. I mean, the fact is that neurodiversity is what makes the world so interesting, right? If we were all exactly the same, thought the same, acted the same, had the same reactions, the world would be really boring. We need, in the same way we need biodiversity, we need neurodiversity, because they're brilliant thinkers who think in different ways, and that produces kind of all of the amazing things that are around us and the amazing art and inventions. So I think, ABA was really working toward kind of trying to make kids appear more typical. And it has not been as effective of a strategy because, again, it's while kids may have learned many of the skills, it was at a cost, and it was at a cost to potentially their mental health. But unfortunately, ABA as a science had the most research behind it, which is why so many people, like insurance companies and everything, grabbed onto it and said, well, this is the treatment for autism. And it used to be a prescription, right? You would get a diagnosis, and I was guilty of this. If anybody looks me up, I was guilty of it, of you had a child, they had a diagnosis of autism, and it was like, well, 20 to 40 hours of ABA kind of as a stamp. And luckily, we have autistic voices now. There's many autistic advocates, self-advocates out there who are saying, hey, wait a minute, this is the impact of that. And so now what we're able to do, particularly those people who are continuing in the ABA field, is to kind of stop and say, wait a minute, we need to redesign what ABA is in order to not produce these negative mental health issues and the sort of negative image that we were giving to our autistic clients. So what we really want to do is, when you're looking at ABA, you want to make sure that you're looking at programs that are affirming, that understand, you know what, you're autistic, and I'm not going to make you not autistic. It's okay to be autistic. That's who you are. Let's figure out how to make you the happiest, productive person that you can be. And there are certainly things, oftentimes outside of autism, even like dealing with anxiety, dealing with some OCD tendencies, that we can work on and improve. You want to make sure that the ABA that you're looking at is child-led, which I think many providers now are really doing. So that is, today the child might want to do X and tomorrow they might want to do Y, and that's okay because they're learning through every process of whatever they do. And the field is trying to become much more reinforcing, like, hey, you did a great job, rather than punishing, which is how it was originally, unfortunately, designed to be. So I'm going to turn it back over to Dr. Ramirez now.
Thank you, Dr. Stevens. So as a result, we do have various researchers have developed floor time, which capitalizes on this child-led concept. DIR, or floor time, is another therapy that's frequently offered as an alternative to ABA, but more often is also used in combination with ABA-based therapies. And so floor time is this relationship-based therapy for children with autism, where both the therapist and the parent engage the child through activities that the child wants to do, typically on the floor, which is why it's called floor time, and then they capitalize on the child's strengths. So, for example, a floor time strategy is if the child is on the floor tapping a toy truck, then the parent might tap the toy truck in the same way, and the parent might include some sort of language to the game. So this encourages the child to both respond to that interaction and continue the interaction. And so a lot of it also includes modeling for the child. Next slide, please. TEACH is another behavioral-based strategy. This stands for Treatment and Education of Autistic and Communication Handicapped Children. Although this method isn't typically covered by insurance, some of these strategies are typically implemented in schools, and it's usually implemented alongside some other approaches or therapies like ABA or occupational therapy. And this just emphasizes structure in the classroom by organizing the physical environment and providing a lot of visuals for the child. Next slide, please. All right, so we just discussed treatments that professionals are often trained to implement and then turn around and help parents implement at home or at school. But what can parents do at home currently? Listed are some general strategies that y'all can implement, but please always consider your child's interests in areas of strengths, their needs, and their developmental functioning. But generally, some prevention strategies include providing structure and consistency. So this includes creating routines when on days that you don't have routines, like on the weekends, so that the child knows what to expect next. It's really helpful if you can also include visuals, such as in the picture, so that language is minimized for the child, again, depending on their developmental area and areas of strength. In addition to consistency in visuals, clear rules are really important so the child knows the appropriate behaviors or the expectations depending on the area that they're in and can focus on what they're supposed to be doing instead. Choices are also really important so that the child feels like they have some sort of power in the situation. For younger children, providing structured choices, so an option between A and B, so having waffles or pancakes for breakfast tends to be a little bit more helpful for their age. And also warnings. For some autistic children, warnings or transitions are a really hard time, are a really area where they need a lot of support in. So providing warnings, such as a 5-minute warning, a 3-minute warning, and then a 1-minute warning, and then a time to clean up warning with a visual like a timer or a clock tends to be really helpful and also helps reduce the likelihood of difficulties during this transition. In terms of teaching strategies, play-based and modeling strategies tend to be helpful for younger children. So just showing the behaviors that you want to see, such as turn taking or including language into play and having a back and forth language or conversation with your child tends to be helpful. Another strategy is social stories or a short, small story with pictures involved that explains social situations to autistic children, such as sharing or giving other people space. And then reactionary strategies typically just includes how you respond to a behavior or how you respond in a situation for your child. This can include positive reinforcement. Something that schools tend to implement is providing stickers every time they see the behavior that they want to see rather than focusing on the negatives. And then providing rewards, whether that's tangible rewards or something less tangible like a 5-minute break. Specific praise. Specific praise is when you give your child, rather than saying a good job, you're much more specific about the behavior that they engaged in, such as good job picking up your socks or good job putting your toys away. So again, just reinforcing the behaviors that they're doing really well. And then following through. So if you say you're going to provide them with a 5-minute break or a small treat after they get 5 stickers or they clean up their socks, just being consistent with those positive consequences. Next slide, please. So these resources will be provided to you following this presentation through our help group website. But generally, some places you can find more information or learn more from includes like Kennedy Krieger, which you can find online, webinars such as the one from today, the help group, or through UC Davis Mind Institute, where they also provide free online parental training called ADEPT. If you're interested in participating in research, we have UCLA or USC currently recruiting for different studies. And as Dr. Stevens had mentioned, parent support groups. We currently offer support groups through the help group, both through Kids Like Me and Kaleidoscope. Next slide, please. And then additional resources is from lived experience resources like the Thinking Person's Guide to Autism, and some online guide like the National Council on Severe Autism or Parents Guide through the National Institute of Mental Health.
I see what you mean, Lori. It wouldn't unmute me either.
Yay.
Thank you, Dr. Stevens and Dr. Ramirez, for the presentation. We do have some time to take some questions today, and I have a few here. So let me just fire away. If either of you want to take the lead or jump in, however you want to do it, that's fine. So here's a question. I don't know if this program was mentioned or not during the talk, but it says, where can parents get the JASPER program?
Yeah, that's a really good question. So JASPER stands for Joint Attention, Symbolic Play, Engagement, and Regulation. And it's also a play-based intervention that teaches social communication to young children with autism. This program was developed here at UCLA pretty locally by Dr. Connie Kasari. You can find trained certified JASPER providers in LA County through their website at jaspertraining.org. They're primarily located at UCLA, but they do offer resources in terms of other nearby locations.
And just, it doesn't say this, I'm following up on Akari. Why would I want to seek a Jasper program versus some of the other things that you talked about?
So this would be based on if the child really needs to focus on some of their social communication skills. And again, it also depends on parents' interests, if they want to explore Jasper versus other treatments, or also how close they are to UCLA, so transportation resources.
Thank you. Lori, this is kind of a big one. You know, a little bit is sort of, we've covered this in full, but let's distill this down maybe. So the question is, what's your best advice for someone who is fairly new to this?
From a parent perspective, my best advice would be twofold, which I kind of addressed. You want to bond with as many parents, and it doesn't necessarily have to be parents of children of the same age, because I think oftentimes learning from parents who have already been through it and know what the other side can look like are just as beneficial as having those peers that are going through it with you. And also being prepared for the fact that sometimes that word autism is hard to know kind of what everybody else is going to be coming with. And I sort of like these autism parent support groups where everybody gets a sense of the true breadth of what autism is and the different ways that children and young adults and adults present themselves as and what their needs are. I think another thing that you want to do is you want to listen to young adults and adults who are autistic themselves. So that's oftentimes through the neurodiversity movement or the autism self-advocacy movements. But you do want to remember that the people, the lived experience people, are autistic people. And so they're going to speak to you from their particular perspective. No one voice speaks for all autistic people. So you also want to keep that in mind, to that, because one or two people say something doesn't mean that that's going to be appropriate or the same way that everybody else with autism feels, because autism is such a broad category that there's never going to be one voice. So listen to as many different voices as you can. Parental voices, lived experience voices, teachers, everything. And then what feels right for you? What feels right for you with your child? And how are you seeing your child thrive? And really go with those areas and moments where your child thrives and try and do that. And that would be my best advice.
So this question just came through, and I love it so much that I even though there's other questions in front of it, I want to ask this question. It says, do parents have the option or to be able to give input to choose which treatment their children receive, or is that decided by LAUSD for children 3+?
Okay, that's a very good question. In general, parents always have the option to choose what intervention they want for their child. The funding mechanism for those interventions might change. So LA Unified is going to have a much more kind of academically focused type of program, and then can also provide you with the speech and language therapy that your child might need, the occupational therapy that your child might need. But keep in mind that LA Unified's role is education. So it's not necessarily the entirety of your child. And I know that sounds terrible, but they're looking at, is this educationally relevant? Whereas a parent or a support provider, we're looking at it from what does my child need, again, to maximize their potential, quote unquote, in the real world. So they might not always be the same. There might be things that you feel your child needs that LA Unified cannot provide. And it might be that when you look at certain schools, it's not just LA Unified, right, but any school district, they might not have all of these things that Dr. Ramirez just presented. Most schools don't have all of them in place and say, oh, you feel your child needs Jasper, they'll be in classroom A, you want your child to have ABA, that's classroom B, you want floor time, that's classroom C. So oftentimes you're going to have to seek some of these therapies outside of the school district. And it's really a matter of what fits best for your child. What is your child like excited to get in the car to go to? But then the funding mechanism would become either regional center if your child is qualified for regional center. It can be private insurance. Private insurance likes to try to railroad everybody into ABA, but there are ways to get around that, particularly if you're looking at social skills training or some more sensory integration, feeding therapy types of issues that your child might have that you want to get therapy for. So I hope that answered your question.
And I'll just add a little bit to that. And this is a little bit more basic than Lori's answer. But as a parent, when you're sitting at an IEP meeting with a school district, whether it's LAUSD or any school district, remember that your voice as an IEP team member is as loud as anybody else's in that room, and maybe can even be louder. So no matter how a meeting seems to be going, your role is to be there to advocate for your child, and you are a member of that IEP team, and it's the IEP team that's making a decision. So take that for what it's worth, but you're there to be your child's advocate, and your voice not only should be a part of it, but should be a loud part of it, and should be considered in whatever decision that the group makes. Dr. Ramirez, how early can children get diagnosed with autism?
Really good question. So diagnosis of autism is rather complex. Sometimes trained professionals can notice signs as early as 16 to 18 months. However, a diagnosis itself is usually not made and is not considered reliable until about the age of 2.
And let's do one more. Absolutely, Victoria. It was a great question. Let's do one more sort of big, sort of broad question, Dr. Stevens. And we have 4 minutes, and I still have to do my closing. So just letting you know that. So this says, I mean, everybody on this call has to have this question somewhere in their minds. It says, how do I deal with all the stress?
Oh, goodness. Okay. I think it is so important that you always remember the airplane rule, which is you have to put your oxygen mask on before you can put it on your child. You have to deal with your own stress, and whether that is through learning mindfulness, yoga, making sure that you take time for yourself. Again, I'm sorry that I say this so often, but bonding with other parents so that you don't feel alone, and maybe they have some other tips about what really worked for them. And finding a team, that tribe, if you will, that you just know you can be your authentic self. And sometimes it is really stressful, and it's okay sometimes to go, I felt like I was going to pull my hair out last night. And I would never want you to think that that means that you don't love your child or any, because of course you do. And we all have those moments where it's just, we just can't kind of take it. So take care of yourself. Find your stress relief. Find what works for you and do it. And don't feel guilty about it, but do it, because if you're not in a good space, you're not going to be able to get your child into a good space. And that's the way to, it's not, you know, I've had parents who say, you know, but I shouldn't be spending time on myself. And it's like, no, you have to, because that's the only way then you're really going to be able to be there for your child.
Okay, there are more questions, and like I said at the beginning, if there are things that we need to get to, I was just busy answering some chats myself. One of the things I will let you know is that we are all available to answer your questions. So if you have anything that didn't get covered here and you have a question, you can email me. If I don't know the answer, I can get it to Lori. I can get it to Anakari. My email address has been in the chat a couple times, but it's hopefully spelled correctly most of the time. It's my first initial last name, so J Bolton at thehelpgroup.org. Dr. Stevens, is that it's the same idea, first initial last name, so L Stevens at thehelpgroup.org. We're happy. Oh, it looks like
you did spell it. You spelled mine.
Yeah, I spelled your last name wrong. I got mine right though, so that's awesome. So you can always do that. We're happy to answer any question like that. And if there are other things that seem to be relevant throughout the chat, we will make sure that we answer those as we go along. We unfortunately have come to our end of our time today. Again, I want to thank Dr. Stevens and Dr. Ramirez for joining us and sharing your experience with us this morning. This presentation, this has been asked a lot of time in the chat. This presentation has been recorded, and we will let you know when it's available to view and share with your colleagues and friends at www.thehelpgroup.org/webcasts. In the chat, the S is always on the next line, so it sometimes looks like it says /webcast, but it is plural, /webcasts when you put it, the URL into your search engine. If there are questions we didn't get to today, we will share some of those with you in a follow-up email. Our next webcast will be April 12th at 10 a.m. Pacific. I believe by then we will be in daylight time. We will discuss the advantages of summer camps designed for children with special needs, and we'll reach out to you as more details emerge about that topic. On that topic, the Help Group's Kids Like Me summer camps will begin on June 12th and are now beginning to accept registrations. You can find out more about them or apply for those camps at kidslikemela.org/camps. And you may also reach out to the director of those camps, Diane Lativio, at dlativio, so DLOTIVIO @thehelpgroup.org. We would also like to invite you to the Help Group's 10th annual Special Needs Resource Fair in person, which we are presenting in collaboration with LA Parent on Sunday, April 30th from 11 a.m. to 2 p.m. And there's some details there on your screen as well. At the Help Group, we always endeavor to provide the best education to our students and to impart what we have learned about best practices to parents, other schools, and other communities. If you would like to learn more about our schools and programs, you may go to our website at www.thehelpgroup.org. You can email our admissions department at admissions@thehelpgroup.org, or you could even call us, 877-943-5747. Thank you so much for joining us. We appreciate your choosing to spend your valuable time with us today. We at the Help Group are here for you when you need us. Have a great day. We hope to see you soon.